And Jen just started the recording. Perfect. Well, we'll get started. It's about 6:04 on the East Coast here. So again, thanks for your patience there with the technicalities. Tonight, I'm excited to introduce someone that's near and dear to my heart. It's actually Dr. Mark Melin, who is also my dad. But I'll do a brief introduction for him, and then I'll let him start here. So I think the just a big question too is, why wound care at a PM&R talk? And my dad is not a physiatrist, but think about patients with spinal cord injuries, traumatic brain injuries who become bedbound. So of course, you got to think about pressure ulcer prevention and management are super important. And maybe those who have done PM&R rotations have interacted with physiatrists who do some wound care as part of their practice. And even from the AAPM&R website, it says a physiatrist plays a key role in managing and coordinating the care for patients with pressure ulcers. And then it also says for specialty wound care treatment and recommendations, consult a wound care specialist. And that's who we have tonight as well. So Dr. Mark Melin has been involved in wound care for about 25 years, and his interests involve chronic wound care, clinical management, research, and education for both patients and clinician teams and really wide variety of subjects, but one, management of lymphedema associated with chronic wounds, endothelial cell function, and the endothelial, and here's maybe a new word for you tonight, glycocalyx. Some emerging technologies in wound care, such as infrared thermography and NearFly, and then utilization of adjunctive micronutrients, such as micronized purified flavonoid fraction, MPFFs, and then also wound biofilm and wound pH management as well to accelerate wound healing. As well, for his training, he received his MD from the University of Minnesota and completed residency in general surgery and a fellowship in vascular surgery at the Mayo Clinic. And then he also really enjoys doing conferences. So he helps run the Mayo Clinic Wound Care Symposium, which is in Rochester in February of 2025. I'll be there, so certainly look into it this year or in future years as well. But he loves his family. He's been married to the love of his life, Cindy, my mom, for 35 years, 4 children, 3 grandchildren, and so really excited to hear from him tonight and be able to share this knowledge with you all. So we'll have a time of Q&A at the end as well. So certainly think of some questions to ask. But thanks again, everyone, for being here. And Dad, take it away.
And Davis, two rescue dogs.
And 2 rescue dogs.
We
Yeah,
do
they need
rescue dogs. So what I'm going to give you all is a talk that I just gave in October down in Chicago as part of the American Venous Lymphatic Society, which I'm a member of. And we actually coming up in February in Rochester at our Mayo Wound Symposium, we have AOCPMR. Oh, Davis, now remind me.
Dr. Jenny Kendall.
Dr. Jenny Kendall is coming up to present at our meeting. Yeah, so we're really looking forward to having her in town and presenting. So a lot of this, what we're going to talk about is chronic wounds, and a lot of this is actually there's a lot of lymphatics in management of this. So disclosures, I do a little bit of research work with Eva MedTech, which is an automated lymphatic stimulation that works on the back, and we published a couple papers on that. So one of the really important things about wound care is just like flying an airplane, you got to run a checklist, and you got to make sure that you've covered these things if you're going to get wounds to heal well. So a lot of words on this slide, but one of the most things we focus on is lymphatic dysfunction in venous disease, diabetes. You have lymphatic disease in even pyoderma and all the inflammatory diseases that we see. We see lymphatic dysfunction in people that have congestive heart failure, on dialysis. So anytime you see swelling or edema in a leg, by definition, it's lymphatic dysfunction. If it's reversible, it may not be truly lymphedema when we think about primary, secondary lymphedema, but certainly there's lymphatic dysfunction if there's significant edema. In the ulcerations we see in the lower extremities, we do perform or try to perform ankle brachial indices and toe brachial indices in everybody. We usually will do TCPO2s at the same time, so we're measuring oxygen concentration of the skin. And this helps us diagnose, is there adequate arterial perfusion to the foot? Because if there's not adequate arterial perfusion, it doesn't matter what you do in terms of managing that foot wound or that leg wound, it's not going to heal. We do a lot of venous competency ultrasound. So we're looking, is there valvular competency in the valves? People are standing up. You're using gravity to look at backward blood flow. And if the valves are incompetent, it'll leak backwards. It forms varicose veins that sometimes you can see on the skin depending on what the BMI is. And most veins now are treated non-invasively with either foam sclerotherapy, or you can do laser ablation, or uh, radio frequency ablation, which is like a microwave type of ablation. But when you see these wounds, there's a lot of wounds that are along the medial aspect of the leg. And just because it's along the medial aspect of the leg does not mean it's necessarily a venous wound. And this is where the importance in differentiation and creating a differential diagnosis is so important, because you can see wounds like pyoderma gangrenosum, vasculitis, vasculopathy. We're going to talk a little bit about this in some of the cases I'm going to show. We are very holistic in looking at nutritional components. So it's wound care, getting wounds to heal. It's like looking at somebody and saying, I want you to go over to that empty lot and build a house, but I'm going to give you zero materials to build a house. All wounds are hangry and they need high dose micronutrients. So we put everybody on 3 weeks of vitamin A at 10,000 units or international units a day, because of course vitamin A is a fat soluble vitamin. Excuse me, so it can build up. So we just do 3 weeks to be safe at 10,000 international units a day. We put everybody on B complex vitamins, so you get B6, B12, riboflavin, and folate. Folate's really important, and that's why folate, they started putting folate in all the food system in the United States in 1998 to help prevent things like spina bifida and other nerve dysfunctions. Everybody has a vitamin D or vitamin D receptor in their cells, and vitamin D, low levels of vitamin D, especially now when it gets so dark and we don't see the sun for weeks on end in the winter, you got to have adequate vitamin D to be able to heal. And then zinc is good for immune system function. You can put people on arginine powders. There's a specific brand out there called Arginate and Juven. They're two different brands, but they both supplement arginine. That helps with vasodilatation. And then the other thing we focus a lot on is micronized purified flavonoid fractions. It's basically orange rinds that are zested and then pulverized so you can absorb it. And the actual medical name of that is diosmin hesperidin, and it decreases ICAM, VCAM, TNF alpha, improves lymphatic tone, venous tone. And it's been used in Europe for decades to help with healing of venous ulcerations. There's been at least, I think, 10 randomized controlled trials. There's been one meta-analysis. So the data is really good. We just started selling it at our store here. I submitted all the evidence about 3 months ago. They started selling it downstairs just within the past 2 weeks. So really good evidence. And if you think about albumin, most people think of albumin as a marker of how healthy are you. If your albumin's normal, you got good nutrition, but albumin is also a marker of permeability. It's like a Gore-Tex layer in all of your blood vessels. So if the albumin's low, you are going to weep out fluid easier, and it's going to make it hard to get wounds to heal. So focusing on albumin restoration is also very important. And that sometimes that can be hard in people that have liver dysfunction, pancreas dysfunction, absorptive dysfunction. Maybe they had a gastric bypass and they're not absorbing well. And so getting nutritional teams involved in this is very important. You also have to turn off the hyperpermeability in the blood vessels. So there are angioedema causing medications that will contribute to swelling in the lower extremities. Swelling in the legs really slows down healing. So one of the most important ones we look for is amlodipine, also known as Norvasc. That's an angioedema causing medication. High dose calcium channel blockers, minoxidil, which we see a lot of men using to grow hair. Chemotherapy can do it. Hyperglycemia, so poor hemoglobin A1Cs can also cause this. Hydroxyurea and methotrexate are also medications that are used. Hydroxyurea we'll see used for myeloproliferative diseases for people that have very, very high platelet counts. So all of these things can really slow down healing. In diabetes management, I'm sure now most of you have heard about Ozempic and Wegovy. These are called GLP-1 agonist therapy. We send a lot of patients in the wound clinic that have elevated body mass indexes over to our bariatric endocrine service to get on a GLP-1 agonist. So it's going to help modify weight. Weight is one of the primary drivers of lower extremity lymphatic dysfunction. And so until we start to moderate BMI, it's going to be hard to get folks to heal up. But the interesting thing, GLP-1 agonists also decrease MACE. MACE stands for major adverse cardiovascular events. So it decreases heart attacks, it decreases strokes. This is all independent of the impact on diabetes, and it's probably because it's so good at anti-inflammatory components. And when you inflame atherosclerotic plaque, it's more likely to rupture, and that's where you're more likely to see a heart attack or a stroke. If you're not sure of the diagnosis, we'll do a lot of biopsies. And biopsies are important because you don't want to miss squamous cell carcinomas, basal cell carcinomas. It helps you diagnose things like vasculitis, vasculopathy, pyoderma gangrenosum. And so it's really good to be, if you're in a wound clinic, to work with dermatology and/or general surgery if you're not performing biopsies yourself. The other thing that really slows down wound healing is biofilms. Biofilm, I tell people it's like don't brush your teeth for 3 months, and everybody thinks that's horrible. Well, that grime layer inside your mouth, that's a biofilm. And there's of chronic wounds, about 70 to 100% of wounds. We just assume everybody's got a biofilm when we look at chronic wounds, and that's very inflammatory, holds a lot of bacteria, and that really slows down wound healing. So even if you have controlled the venous and you've controlled the diabetes, you've controlled the arterial flow, if you got significant biofilm, this is not going to heal. And we're going to show you a lot of biofilm stuff. Your skin pH is 5.5. You're born with a pH of 7. It acidifies, and then it gets a microbiome on the skin that's very protective. When you have a chronic wound, your pH of that wound goes up to 7.15 to 9. Higher bacteria like Pseudomonas, Serratia, E. coli. So simply by helping to decrease wound pH, you can, and again, the stuff we use, it's called VOSH or hypochlorous acid. Some people have tried Dakins in the past, which is a World War I technology that was used to salvage limbs that Dr. Dakin, who is a German biochemist, put together, but that's dilute bleach. So that's a higher pH, and anything that you couldn't put in your eye, you should not put on a chronic wound. So Dakin solution has kind of fallen out of favor. Hypochlorous acid, pH of 5.5, which you can put in your eye in very sensitive areas. This has now become the standard of care in terms of management of these chronic wounds. It helps to decrease the wound environment. It doesn't kill bacteria, but it makes a lower pH, and pathological bacteria simply can't survive in a low pH. Compression obviously is incredibly important, whether it's compression stockings, short stretch wraps, Velcro compression wraps. Flat knits are more for chronic lymphedema because they're good volume containment versus the stuff we use in wound care. So we do a lot of short stretch wraps. ACE wraps are totally different than short stretch wraps, which I'm sure you all know. An ACE wrap is elastic. When you put it on, it can act like a tourniquet, and you want to put on something that really has a good high resting static pressure and short stretch wrap that do that without creating a tourniquet effect. We use some degree of what are called advanced skin substitute products. They're also now called CAMPS, CAMPS, which stands for cellular acellular matrix-like products. And these are amniotics, placentals. They can come from fish skin. They can come from sheep stomach. They can come from pig bladder, pig intestines. There's all sorts of different ones you can use. Obviously, tobacco cessation is huge. You got to ask about not just smoking, but vaping, and also ask about chewing, because all of that nicotine will decrease. And I always put this on when I'm talking to our leg ulcer team, because just if you're in a vein center, too many people assume just because the patient walked in with an ulceration, it's automatically a venous ulcer. Don't don't you got to make the diagnosis. So the critical team players for wound care, dermatology and dermatopathologists who are really good at helping make diagnosis, rheumatologists, vascular medicine, surgeons, radiology, interventional radiology, and then the patient and the family are critical. Like today when I was seeing patients, when I talk to patients, I say, just tell me when the last time your leg was normal and then walk me forward. And it's really interesting what the stories you hear from patients, and you can start to really figure out differential diagnosis just by understanding those components. So you really got to be a good listener. Ask about previous history of skin cancer. When you ask about skin cancer, melanoma versus non-melanoma, two distinct entities. Melanoma is obviously much more potential for metastatic versus the basal cell and the squamous cells, which tend to be different. And it's amazing what you'll see on patients' cell phones. They'll bring out a whole library of pictures of their, and it's amazing to watch the transitions. We'll oftentimes take pictures of their cell phones and put that in the medical record to show what's going on with their wounds. It helps in terms of differential diagnosis. So here's our first wound. The picture on the bottom, and this is actually a nurse who has stood for many, many years, no history of blood clots, ulceration on the lateral aspect of her leg. So She doesn't know what the diagnosis is. This is the first time consulting. She's had no studies. So when we talk about and thinking about the differential diagnosis, could it be a cancer like a basal cell, squamous cell? Could it be pyoderma gangrenosum, a vasculitis, a vasculopathy? She hasn't smoked, no high blood pressure, no high cholesterol, no family history of peripheral arterial disease. So unlikely to be arterial disease. Again, she's a non-diabetic. We saw somebody this week who had a brown recluse spider bite, so you'll see those every now and then. It could be something like that. Could it be venous? Could she have venous insufficiency? So we talk about, and then clearly as you're looking at it, there's inflammation, there's swelling around the wound, so there's peri-wound dermal lymphatic dysfunction. There's a lot of biofilm that what looks almost like cheese on a pizza, that's the biofilm. That's really laden with a lot of bacteria. So typically greater than 10 to the eighth critical colony forming units you'll see in a thing like that. We typically don't culture these because it's going to show a lot of stuff. The most important thing to do is to breed it. So you can use a knife. We put on 4% lidocaine. You can inject lidocaine. So debridement important. And then we use the hypochlorous acid. We may do that dressing change twice a day to lower pH, help to get rid of the bad biofilm. So we ordered up the venous ultrasound studies, ordered up the arterial studies, which were normal. And here she comes back to clinic 3 weeks later. You can already see a little less redness, less swelling, and more granulation tissue development. So we're going the right way. Here's what her ultrasound shows. You can see the red squiggly lines are venous insufficiency. So she's got backward blood flow and she's got veins that are going right to where this ulcer is. So by definition, those are pathological varicose veins. We sent her on to see the interventional radiologist to get foam sclerotherapy and ablation of the veins that don't work. So the diagnosis of venous leg ulceration with uh, skin lymphatics that weren't functioning correctly. And then this is 83 days later. So now she's had her foam sclerotherapy, she's had her treatments, and she's had all the micronutrients we talked about. She's had her vein formula, which is the micronized purified flavonoid fraction. And here she is 83 days. Now, this is her healing without any advanced skin substitutes. The lines in the skin come from a product called Edemaware. It does micro circumferential uh, manual lymphatic drainage. So if you talk to a certified lymphedema therapist, and I'm sure this group knows really well about MLD, this is like doing simultaneous or continuous MLD circumferential at 8 millimeters of compression is what Edemaware does. So we use a lot of this underneath compression, whether it's Velcro compression or a short stretch wrap. So we're doing dynamic dermal um, interaction for the MLD-like effect to stimulate dermal lymphatics, plus the overlying static compression. And you can even see if you look at how much edema is in this leg, that edema is completely resolved in 83 days when it's healed. So this is to get somebody with a long, I think she'd had this wound for well over a year. And to get it healed in 83 days, and it has not recurred since I last saw her. And this was March of 2024, so we're going on almost 10 months that she's had no recurrence. So here's a gentleman, 50-year-old, wounds more than 10 years, and he's got a venous malformation called Klippel Trenaunay syndrome. So he's got a larger right leg as compared to his left. This was at the initial consult. We have a team here of people that work with these venous malformations like this. And when it gets into complex wound care like this, we get involved. So you can see it's right over where his Achilles tendon is. He's got a lot of hyperkeratotic tissue, a lot of biofilm, a lot of uncontrolled swelling in his leg. You can see the lines up here where all the swelling is. And it's really a big wound. It weeps a lot. It smells because the tissue's all necrotic. So going back to basics again, we know the diagnosis is Klippel Trenaunay syndrome. We had him seen by the dermatologist. There was no concern about a transition to a dermal skin malignancy. So we started on, he was a chewer, so we had to get him off the tobacco. He's a non-diabetic. We had to do good dermal lymphatic stimulation with compression and Edemaware, and then biofilm mitigation with a Vash. So we started twice a day, moist to moist, Vash dressing changes of the hypochlorous acid. It's important. A lot of people talk about wet to dry dressings. If you dry out a wound, it's kind of like making beef jerky. You always want to keep wounds moist. So twice a day, moist to moist dressing changes can be really good for controlling biofilm. And here's what his toes look like. So this is all just uncontrolled biofilm buildup between the toes. And this is literally because he's got such bad lymphedema that the lymphatic fluid weeps through the pores of the skin. That's called lymphorrhea. And then it dries on the skin. And this is kind of dry proteinaceous discharge on the toes, and it just builds up. So you've got to get clean between the toes to get all this stuff taken care of. So biofilms impact everything we do in wound care. It delays wound healing. It results in increased risk of infection and lymphangitis. So, and you got to treat the whole host to really have an impact, as we talked about. So you got to make sure peripheral arterial disease taken care of. We deal with a lot of transplant patients. I had a heart transplant patient in here today with a chronic wound, and with lymphedema because he's also got some degree of heart failure now. But all this stuff, if you're not controlling all this stuff, you're going to have a hard time ultimately controlling the biofilm. So here he is now. I think this was 3 months later. No, I'm sorry. This is much, much farther. This is October of 2023, and this is now a year later. So these clipple tendinate patients can take a long, long time, but you can see it's a really significant change. You can see how much he's epithelialized on the back of his calf, where the Achilles tendon was. He's now got really good granulation tissue. He's developed excellent granulation tissue along the lateral aspect of his leg. But and then here he is even further down the road, you can see how he's really epithelialized and done a great job. And look at the difference in his toes. So once we get the biofilm, the limb volume reduction, you can see how much smaller his toes are, cleaning between the toes, and doing special bandaging around the toes to decompress the toes. And then just dealing with the hygiene and the lymphorrhea part, you can see this makes a big difference over the course of time. But you have to warn these patients up front. This has been going on a long time, 10 years. It's going to take us a good 12 to 18 months to really get some of this reversed. But just look at how much healthier his skin is over the course of that year. So here's a 60-ish-year-old gal, 12-month history of a right leg wound, really significant biofilm. You can see depth, you can see the edema. So it goes back to what is the diagnosis. So we're going to order up the venous ultrasound. We're going to order up the ABIs. We're going to order up a diagnostic biopsy. We're going to start on controlling the swelling with the edema wear and the short stretch wraps, and we're going to control biofilm with doing twice a day moist to moist hypochlorous acid, again, Bosch dressing changes. You can see just in about 3 weeks the significant change in her wound care bed just with controlling biofilm, getting limb volume reduction down with compression really made a big difference in this patient. All right, here's another patient. This is the ankle mortise, so the toes are the ankle sitting here, or I'm sorry, toes are sitting over here, ankle leg is going up this way. So if you look at this, it's, well, she's got dead tissue here, that's dead skin that's an eschar. She's got underlying exposed dead tendon. If you put a finger underneath there, you can actually wrap your finger underneath that tendon. That tendon is dead. And then if you look at the rest of the foot to look at the pattern, she's got a heel ulcer, an ulcer at the inside of the ankle. She's got one on the back of the calf. So multiple different ulcerations starts to raise your concern about peripheral arterial disease, a vasculitis, a vasculopathy. So uh, and she really had a significant odor as well. So there's an infection. So there's a score we use to look at how to grade, especially if we're concerned about critical limb ischemia. It's called the Wi-Fi system. So it's wound ischemia foot infection. And what that allows us to do is look at and stage how much risk is the patient at for a leg amputation from the initial consultation. So she was pretty ischemic with a wound ischemia score of 2. We base that on the ABIs and the TCPO2 measurements. Um, she had a significant, I'm sorry, ischemia here, foot infection was a 2. And so ultimately her total score was a 5 with a stage 4, which put her at about a 40% risk for a leg amputation. So this was critical limb ischemia. She had extensive tibial artery occlusive disease. We had to get her in with our vascular group to reestablish blood flow. And again, this is just going to take months to get this healed. You're going to need all these tendons to breed it. You're going to need all this to breed it after you get good restorative blood flow to heal folks. Here's a gentleman we're still currently working with. He's
A wound
uh,
care
60-ish-year-old gentleman that's got
presentation
sickles.
from Davis's dad.
he's got a gentleman that's 60-ish year old who's got sickle cell disease. So he's got wounds on the outside of both legs and the inside of both legs at the ankles. And one of the things we were doing with him again was biofilm mitigation. We use the all the specialized vitamins, and then on him we're using a specialized platelet-derived exosomal therapy. We're using it only in compassionate care. We got about 10 patients going right now. Each one of these patients we have to get approved by the FDA for use, and then we have to submit each individual one to our investigational research board for utilization. But this is a Mayo-derived therapy that's in phase 2 trials right now for diabetic foot ulcers. And we have the good fortune to use it for some of these other types of patients. So you can see this is over the course of um, several months, and you can see that he's gone from pretty big wounds with not very good granulation tissue, and the wounds have gotten slowly smaller. But again, sickle cell disease takes a long time to have an impact. Here's a scalp wound, chronic skin exposure. He worked outside. So the first thing to think about would be a malignancy of some type. So he's got necrotic tissue here. You don't know how deep it goes. You're going to end up ordering an MRI because you want to look at scalp, bone compromise. Is there osteomyelitis? Does it actually go through the tables of the bone? Is there any compromise in the skull? So again, diagnostics would be biopsy. You're going to do radiologic diagnostics to help you in terms of management. And so this was a squamous cell malignancy that ultimately needed debridement, and our ENT folks to fully surgically debride and then to work on getting this to heal. Some of these folks will even go on to require chemotherapy and require like latissimus flaps where you swing up a muscularized flap onto the top of the scalp. We've seen some of those folks get this as well. Next case is a 50-ish-year-old gal. She is a dog groomer. She stands for long hours. No history of a deep venous thrombosis. These are very painful. So usually in somebody like this, especially if she's got a little bit of an elevated BMI, you would suspect this looks like a venous ulcer. The thing that makes it look odd for venous is it looks really punched out, and it looks really uh, indurated around the skin edges. And it's just in a little bit of an unusual location for venous leg ulcer, and there's multiple of them. She's not diabetic, no tobacco or alcohol. These came on spontaneously. And again, this is one of the things where oftentimes people say, well, it's a venous leg ulcer. They'll get a venous study. If there's some venous abnormalities, they'll just treat the bad veins, but then the wounds don't get better. So we were clinically suspicious enough that we sent her over to our dermatologist to get a biopsy. And what the diagnosis is livedoid vasculopathy. So you treat vasculopathies with in a totally different pathway than you would venous insufficiency. So she ends up on steroids, and she ends up on really a process of managing the vasculopathy. And sometimes we'll put these people on oral anticoagulants as well to help the microvasculature improve. But again, you can see all the biofilm in here. So you still got to do the edema reduction, the micronutrients, and the VOSH treatment and this type of thing to help. Here's a 40-ish-year-old male. He's a spinal cord injury, wheelchair bound. And it's interesting because he came in saying, well, I just keep hitting my legs against my bars on the outside. So he's got symmetric wounds outside of the left leg, outside of the right leg. He's got multiple molds that were a little unusual. The one thing, though, that he said was the lesion on the outside of my left leg. I've had these for many, many months. This one on the outside of my left leg is growing much quicker. So anytime you say significant change, short period of time, you should first be thinking about, is there either the trauma caused a hematoma and the hematoma is expanding? Is the patient on anticoagulants? Or the other thing is it a malignancy? Because you would expect malignancies to grow if they're not treated appropriately. So really, again, important to listen to what the patient's saying. Think about differential diagnosis. Don't just blow this off because it's symmetric. And the patient's giving you a clue here saying, well, this has really gotten bigger. So we sent the patient for a biopsy, and sure enough, it was a lentiginous compound nevus with severe atypia. So this is something that could go on to develop a malignancy. So they ended up doing almost like a Mohs type procedure, got rid of the entirety of it so that you have clean margins. And then we worked on getting that to heal up. Of course, you're going to eliminate the trauma. We're going to treat this, find ways to pad, etc., so that we don't have that type of an issue. Oh, I actually just saw this patient back in clinic today. This is a 60-ish-year-old gal who's got 7 years of this really burning pain in her feet. Her feet are just hot. She literally came in today. I think, almost 0 degrees in Rochester. She came in wearing no socks and basically flip-flops. And they'll go through these cycles of I'll soak my feet in cold water. My feet really burn. They hurt. They're painful. ABI, so the ankle brachial indices are normal. She's non-diabetic. She doesn't use any tobacco. Feet are blaring red. Davis, have you ever seen something like this? Anybody on this call have any
No.
idea what this diagnosis is? Because this is something I really didn't know much about until I started working here. And they actually have one of the world's largest clinics for this condition called erythromyalgia. So it's an autonomic dysfunction where you lose sympathetic parasympathetic balance and you have shunting of blood flow to the skin. So but you end up with non-nutritive flow. So then you go on to develop a lot of edema and you develop ulcerations. So when I first saw her June of 2024, so a little less than a year ago, my focus was on endothelial cell health, dermal lymphatic functionality, and the wound care. So you can see a close up here. Look at how her toes all look like sausages, right? So she's got dermal lymphatic dysfunction. But these ulcerations are because even though I can feel a pulse, there's a disconnect between the macrovascular flow in a dorsalis pedis and the microvascular flow in the skin, where you're talking about blood vessels 1/3 the size of your hair at 8 microns. That's what's causing these ulcerations to develop, because they're shunting from, just say, 200 micron vessels, arteries, to 200 micron veins. So pretend you're going down a highway and it's an Amazon truck. If the Amazon truck goes from big city to big city, that's called transportation, but that's not delivery. To get into a driveway and drop off the Amazon package, that's delivery. So what's happening in her is her Amazon truck's full of red blood cells and oxygen going through the main big blood vessels, but then it connects with the main big veins and it's never delivering to the individual cells oxygen nutrients. That's the thing that's causing all of this problem. So this is erythromelalgia, very uncommon, but I think I got 4 or 5 patients we've had come through our wound clinic just because we have a erythromyalgia clinic that's based in our dermatology department. So here she is 3 months later. Now we've done dermal lymphatic stimulation. We've done B complex to help endothelial cell function. We've got her on vitamin D. We put her on the micronized purified flavonoid fraction, the diosmin hesperidin. We put her on vitamin C. But really dramatic difference in 3 months. You can see the edema is markedly better. Her pain was better. And then she comes in today and her foot it's all red like this with only one sore. And we think what's happening is the cold weather is just re-exacerbating this cycle, this warm cold cycle that increases the shunting in the small blood vessels. So and so we're working on getting that part taken care of, but we can certainly make a difference focusing on these common elements again. Here's a 70-ish-year-old gal, 3-year history of a draining left ankle wound. There's a couple lines where she's had massive ankle surgery. She fractured it. She ended up with a total ankle 20 years ago. And she's been having this going on for a long time. She's seen multiple wound clinics. She's had advanced skin products put on. She had a prior split thickness skin graft from her thigh. No history of skin cancers. Non-diabetic. She's had biopsies. There was no malignant transformation. No rheumatoid arthritis. No tobacco. She's not on Norvasc that causes angioedema. So if you look at this, your first suspicion is always, is there underlying infected hardware? Because anything that's a draining sinus long term. So x-rays of feet like this can be incredibly important. So here's what her x-ray looks like. There's her total ankle joint. Here's the screws. Here's the plate. And when I put a metal probe through this little hole, I can touch on metal. So if you're touching against a screw, a metal plate, a foreign body, by definition, this whole thing is infected. And so the ways to manage this are really complex. This could be anywhere from Could you do an ankle fusion after you have to take all this hardware out? And some of these patients actually end up with below knee amputations because of this. So this is a really, really tough situation when you've got this much hardware in there and it's infected and it's been like this for about 3 years. So you can't just treat the surface, always have a suspicion what's going underneath. And if the patient can't tell you, plain view x-rays of the feet are incredibly helpful for helping to make the diagnosis. Here's a 50-ish-year-old nurse, works here at the institution, spontaneous onset of a ulceration in the lateral aspect of a right leg. Now, it looks a little bit like that first nurse that we had, right? That first nurse had a ulceration, but see how this isn't quite, doesn't have that reddish hue. It's more punched out. The edges are raised up. It looks a little bit deeper. So what's the differential diagnosis of this? This ended up being pyoderma gangrenosum. I looked at this and said, this has got to be either a squame, basal, or an atypical covering that broad category of pyoderma. So we sent her upstairs, got a biopsy, and sure enough, it was pyoderma gangrenosum. So you can't make a definitive diagnosis of pyoderma on a biopsy. What you'll see is a lot of basophilic infiltration on the biopsy, and then the clinical story of kind of spontaneous onset. Sometimes it'll be associated with Crohn's or ulcerative colitis or other types of bowel disorders that cause diffuse inflammation. But the principles ultimately are the same. So she gets put on steroids. We do biofilm mitigation. We do edema wear. And this wound went on to heal up for her in about 6 months. We did all the micronutrients, etc. So a lot of that same commonality. Here's a 50-year-old guy. He lives over in Wisconsin. Now look at the extent of these wounds. Again, pattern recognition. 50-year-old male. He does chew tobacco. He's non-diabetic. Spontaneous onset of wounds. This doesn't look like any venous wound I've ever seen. Doesn't look even like an arterial wound. Really extensive. He's had destruction of all of the skin, not only on his left leg, but look at what's going on his right leg. He's got very similar types of extensive wounds on the right leg. So whatever this is, it's not very good. And again, we need help from our dermatologist in terms of a biopsy to help nail down the definitive diagnosis. In the meantime, while we're waiting for the biopsy, start all the same principles. Biofilm mitigation, you can do Vosh moist to moist dressing changes twice a day. We can put on short stretch wraps. You can see how edematous this is. If you pay attention on the back of his left calf, he's actually got, that's Achilles tendon that is essentially ruptured. That Achilles tendon is almost non-intact, and a lot of that is necrotic. We ended up debriding away some of that necrotic Achilles tendon. And so differential diagnosis, it ended up being necrotizing vasculopathy. So again, back on steroids and all the basic principles in wound care to get this taken care of, and you got to get them off the chewing tobacco, because if you're using chewing tobacco, there's almost no way you're going to heal this kind of stuff. So here you can see them about 4 months later. Much, much better granulation tissue, edema reduction. So really significant change in the course of 4 months. And most patients will tell you within a month, I can see a difference using the techniques that we're talking about. All right, pressure injury case. So this was a gentleman we just actually saw recently. I'm going to present this, Davis, at our ambassador case on February 27th. So this gentleman's a 40-ish-year-old stage 4 pressure injury. He had a traumatic transection of his spinal cord, ended up as a paraplegic. And this was 15 years ago. He lives with his family. He's got really great pressure offloading with a Rojo cushion in his wheelchair. He's got a great mattress. But he developed this wound, um, let's see, I think 2 years ago. He has to do self-catheterization 4 to 5 times a day. He does not have a diverting colostomy, but it's really above the anal crease. So his anus is way down here, so he's got really good hygiene. But here he sits with this significant ulceration. The interesting thing was of negative pressure wound therapy. So VAC had been tried on this. Some topical treatments had been performed, but he had never gotten a simple CT scan to see what's going on in the hole. If you put a metal probe down in this hole, it's down into bone, and the bone was really soft. So if you look at the stages of pressure injuries, and this is a paper that I was on with one of our infectious disease fellows that was published late last year on the evaluation and management of stage 4 pressure injuries. So stage 0 is skin redness that's non-blanchable. Stage 2 is where you have disruption of the dermis. Stage 3, now it's getting quite a bit deeper into the adipose tissue. And stage 4 is where you're all the way down into exposed bone. So these are going to be the most difficult to deal with. You want to, if you start to see somebody in the hospital stage one pressure injury, you want to start making changes right away so you don't end up with an ulcer. Now, the interesting thing about our paper, we were one of the first to really address the significance of biofilm in stage four pressure ulcerations and management to accelerate outcomes. So again, to walk through the stages of what happens with biofilm, there can be biofilm attachment that's easy to get rid of. This would not be significant contributing to a non-healing wound. Wound colonization is less than 10 to the fourth critical or colony forming units. And then once you get where they get what's called quorum sensing and they create a gel around itself, this is where you get greater than 10 to the fourth. Now you have biofilm maturation, you have tissue penetration, and now you have a significant impediment to wound healing that can result in either chronicity or can result in an acute infection. So topical treatments here can work really well. This is going to take topical treatments plus systemic antibiotics to make a difference. So, we just simply ordered a CT scan, and here's his CT scan. Here's the level. It's right at where that ulceration is, and he's got total destruction of his coccyx. So his tailbone and then moving up towards the sacrum was all necrotic. This is actually air and gas bubbles that are in the abscess and the phlegmon that's back there. He doesn't have compromise into here's his rectum right here, or the distal colon. So this was the problem, is that he had underlying infected bone that kept wanting to drain out. So until you get rid of this is never going to heal. So general surgery colleagues took him to surgery. They carved out all that necrotic tissue, carved out the necrotic peri-wound margin, and put him on systemic antibiotics. And now he's just doing moist to moist dressing changes twice a day. And I just talked to him on the phone yesterday. He's from out of state. He's really this wound is accelerating in terms of closing, so doing very well. All right, Davis, how are we doing on time?
We could probably do like 5, 7 minutes. 6:45
Perfect.
right now.
Couple more interesting cases, and I think we're going to be done. 70-year-old male. Now, whenever you see patients that are transplant patients that are all immunosuppressed, right? So they don't reject their organs. And when you see wounds like this, you should always think this is a cancer until proven otherwise. So look at the edema in his left leg. It's massive. So chronic lymphedema and this fungating ulcerative lesion on his foot. So this could be a fungal infection, but again, you got to always suspect malignancy because malignancy is dealt with in a different form than fungus is going to be. So the first thing you got to think of, I got to get the edema reduced, but I got to get him to a dermatologist and we got to get a biopsy and make a definitive diagnosis because again, people that are immunosuppressed have a much higher rate of developing malignancies because the immune system is the cancer surveillance system. So we got him a biopsy. Sure enough, it's a squamous cell malignancy. So this takes down the pathway of dermatology, could be irradiation to treat this. Certainly surgical debridement. So there's a bunch of things. And then you got to get clean margins because how do you know where the last cancer cell is along this margin? But we started them out, and this really smelled because of how much dead fungating tissue there was. We're going to do this case, and then we're going to quickly go through something, Davis, and we're going to be all set. 80-ish-year-old gal. This is actually a gal that had peripheral arterial disease, but the important thing here is lymphedema 40 years in her left leg. Anytime somebody's got lymphedema 40 years, think of lymphedema also as immunosuppression because your lymphatic system isn't working well. If you've got chronic lymphedema, she had these quickly growing black spots on her leg. And anytime you think of or hear about lymphedema, black spots on a leg, think angiosarcoma because it's one of the most aggressive forms of cancer. So I saw this patient, sent her right upstairs. We got a biopsy same day. Sure enough, this was an angiosarcoma. And pretty extensive spread already underneath the skin. So the first recommendation for her was an above knee amputation. So these are things you don't want to miss, and you don't want to mismanage because if you say, well, I just think that's a little bit of eschar and we're going to debride this and then you're going to come back and see me in a month, you've missed the opportunity. So again, key elements here, chronic lymphedema, rapidly growing lesion, unusual. Those are the things to look at. So one of our dermatologists in our group here, Afsana Alavi, and Jenny Brott, she's one of the lymphedema therapists. Afsana is a wound care trained person who's up in dermatology. They published this paper late last year, Association of Lower Extremity Lymphedema Non-Melanoma Skin Cancers. And this is just to show that patients that have chronic lymphedema all have an increased risk of squamous cell and basal cell malignancies compared to patients without lymphedema. So, and again, this doesn't involve the angiosarcomas, which again are incredibly rare. So, anytime you have a patient with chronic lymphedema, think it's immunosuppression. They're going to be at higher risk for skin malignancies. And therefore, if you see any lesions that are unusual in chronic lymphedema, make sure and biopsy that quick. And Davis, perfect timing. We're going to end with that
Excellent.
slide. Um, so I'm going to stop sharing and we can go to
Yeah.
and see if there's any questions here in the last couple minutes, and then we'll get you all back to studying for the night.
Well, no, thanks, Dad. That was excellent, and I never get tired of seeing those photos. It's pretty amazing just seeing them
Well,
heal up. So
Davis told me bring all the ones that look really nasty. So these are some of
yes,
the nasty wounds.
yes. Well, we got a few minutes for questions. So feel free to unmute and ask away.
Say just to make one comment, there is in wound care right now, there's very few wound care fellowships in the United States. Most of those fellowships are done after you've done board certification elsewhere. And right now, wound care is not a board certified, distinguished subspecialty. So we're working at a national level with some teams. There's a lot of good people that are working on this for fellowship development, and ultimately, chronic wound care like this should be a specialty of itself. I'm going to shift my camera over here since I'm looking at my other screen now.
And actually, that goes off of there was one question that was submitted beforehand, and it says, "What can I do in residency as a PM&R resident to stand out for wound care fellowships? And also, what are pathways that can be taken to be a certified and practicing uh, wound wound care as a PM&R trained physician?"
So if you're interested, ultimately, Davis can connect you. But if you're looking for wound care fellowships, just reach out to me and I can tell you where the current active ones are. We had one at the University of Minnesota for a year. It takes funding, right? I mean, wound fellowship positions, just so everybody understands the economics, you're talking 100 to $150,000 a year to fully support a fellowship. And that's a single year. And none of that money goes to that's to pay the fellows salary, benefits, cover liability. None of that goes to the training physicians. And that's true in almost all practices. So funding is a big deal right now until it's board certified, which takes about 15 fellowships across the nation. Then you can approach the American Board of Specialties and request a review. Then once it's a board certified subspecialty, now CMS, now you can talk to CMS about funding because that's where a lot of the funding comes for residencies throughout the United States and fellowships is working with CMS. So there are there's 3 or 4 good certification tests to take out there right now to get at least a certificate of specialty in wound care. There's entry level ones to almost a PhD quality level uh, test that's offered by the American Board of Wound and Medicine Surgery. So, yeah, there's some options right now. Concentrate on getting your board certification, and then look at the wound components.
Okay, great. Any other questions?
Here in the anything else in the chat? Got it. What are some of the basic wound care supplies that you would hope medical students be familiar with for uh, so one of the most important things literally is this VOSH, this hypochlorous acid. There is another company out there called Pure and Clean that makes a really good hypochlorous acid. They actually help take care of the U.S. Summer and Winter Olympic teams as well. But so know about hypochlorous acid because if you have access to VOSH, then you can treat almost anything. I mean, putting that on twice a day and changing it will help almost every wound you can deal with. And if you can't get access to VOSH, acetic acid, which is 1% 1% acetic acid, which is basically vinegar and water. We have patients who can't afford the Vosh because it's not covered by insurance companies, and they'll do clean white vinegar, which is 5% acetic, 5%. So white vinegar is 5% acetic acid when you buy it from the grocery store, and with clean water. And so you can make up a 1%. So by diluting it, serial dilutions, you can get to a 1% acetic acid, and you can put that on any wound and it's never going to cause a problem. So I think it's if you take 100 mils of 5% acetic acid and you add 400 mils of clean water, you'll have basically a 1% solution. So acetic acid is another really good thing to do. If you run into people with Dakin solution, again, Dakin solution is a high pH. In 2025, there's just not really a good reason to use Dakin solution as dilute bleach, unless it's a young kid with, um, they'll do basically soak those kids with impetigo. They'll put them in a bathtub, 40-gallon bathtub. They'll add in a quarter cup of bleach, and that can really help those kids with impetigo. But those are young kids with an acute condition, not chronic wounds. And then in terms of just sheer dressings, there's all sorts of foams. There's blue foams, gray foams, antibacterial foams. A lot of it really depends on what institution you're at and what they've contracted with and what they have. If you're looking for really good education, there's almost always wound care nurses now in every institution. Go hang out with a wound care nurse for a day and you'll learn a lot about what options are. I see one hand up from somebody that's got on a Liberty shirt.
Yes, yep. I have a question for you. My name is Teddy Hausman. I'm an OMS1 student. Um, just as someone who's looking at different specialties and just getting to know what about them, what got you interested in your role now? Like how did you get there, and what stood out to you as you went through that process?
In wound care,
Yes, sir.
a lot of it was from general surgery training and learning about they the institution that I joined when I finished training. There's a whole nother backstory that we won't go into, but they were opening a wound clinic and they were looking for a wound clinic director. And so I thought, well, I've done general surgery, I've done vascular surgery, I know a lot about wounds, so got into helping out run that wound clinic and quickly learned I knew almost nothing about wounds. So a lot of it was trial and error and just kind of being, boots on the ground and being present, and the physical therapist and the lymphedema therapist and the wound care nurses, we all kind of learned together. We work together as a team. And that's one of the most important things about wound is it really is a interdisciplinary teamwork. So in this wound clinic, we have wound care nurses, we have nurse practitioners, we have physician assistants, we work closely with our lymphedema therapist. So we really have a broad range of interdisciplinary care. But you're going to learn if you get into a wound clinic, you'll see that there's a lot of people involved, including podiatry. You can learn something from all of them in terms of management. But I think it's having intellectual curiosity and how can you really improve wound care. But I think you have to understand all the way down to the endothelial cell level. And then you guys, as in osteopathic medicine, you guys know lymphatics better than anybody in the nation. If you understand lymphatics, you can make a huge difference in outcomes in wounds because every wound has lymphatic dysfunction.
Awesome. Thank you so much. Very interesting.
Yeah, you're welcome. Thank you.
All right, we got time if there's one more at all. I guess, Dad, any follow-up resources you'd recommend students to look at as well, just as maybe they're on rotation or maybe as they're in their intern year, or PM&R residency too. Any specific resources you'd
Yeah,
recommend?
there's one paper that I really like on it's called immunonutrition. So immuno, IMMUNO, and the nutrition. The author is Barbul, Barbul. I think he's still down at Nashville, but understanding nutrition and wound care is critical. And so it's again, nutrition is one of those things that's just not practiced well by a lot of physicians. So if you guys have a head up on nutrition, because nutrition ultimately plays a part on everything we do for patients. In the last 6 months, I've had 4 people in this wound clinic, vitamin C deficiency in 2025. That's called scurvy. and scurvy should never occur. But here we have people that are now eating poorly nutrition, too much canned goods, not enough fresh fruits, vegetables, food's expensive. And if you've got a vitamin C deficiency, by definition, you're never going to heal. So, and thinking about just simple stuff like that is really important. So I would read up on, you could literally just Google in PubMed or any search engine, nutrition and chronic wound care. And I would read some of those resources because that'll give you a huge head up, but also applies to people with congestive heart failure, with liver failure. All those folks really need good nutrition if they're going to heal.
No, it's great. Thank you so much. Yeah, it so often goes back to food, doesn't it?
Well,
And
I mean, how many people on this call like to eat? And so when you look at wounds, every wound is hangry. There's something wrong in the if I was going to ask you to go to an open field and build a house, but I'm going to say I'm going to give you no supplies. That's kind of what happens in a lot of wound clinics with lack of nutrition. So you got to give them the basic elemental stuff. Vitamin A, B, C, D gives them all the basic elemental stuff to start to heal that wound, and especially A and C because they're so integrated with collagen formation. So you can have all the fibroblast in there, all the cells you want, but if they don't have the foundational building blocks for production of collagen, the wound's not going to heal. And then if you make weak collagen, it's still not going to heal. So you gotta hit them hard with micronutrients, and just a regular multivitamin doesn't do it. A lot of our patients come in, they're already on a Centrum, they're on a Fred Flintstone, they're on a Gumi, and they look at me and they say, "Well, I'm already on vitamins." And it's like, well, it's not working because otherwise you wouldn't be here. So we got a super dose use. So, all right, Davis, this was really fun. Thank you for inviting me. I appreciate it. We're looking forward to seeing you coming up here in at the Wound Symposium. Davis is working on a great poster on epidermolysis bullosa. That's going to be a lot of fun, and it's going to be a really fun meeting.
thank you guys for coming. Yeah, and Dad, thank you so much. We really appreciate it. And thanks again, guys, and hope that everyone has a great evening.
All right, enjoy the night. Take care. See you later. Bye.